Hello and welcome again to another edition of the Osteopathic Lyceum podcast. I'm going to attempt to speak about something that I don't understand internally. To say that is not to say something is right or wrong, it's just to say that I don't necessarily understand the desire for something to occur or for people to understand something in a particular way. So it's not necessarily, again, that it's right or wrong. It's just I kind of don't get why people get so hung up on it, other than the process that I would tend to call cultural reproduction. Somebody before you that you learned from thought this thing was important, therefore it's obviously important because that's how you learned it, and you didn't learn it any other way, therefore it matters. Okay. The desire for cognitive understanding of mechanisms in a given moment in hands-on therapeutics doesn't make sense to me because of the amount of assumptions that you have to make. So I've talked about this before. This will sound familiar to those of you who listen consistently. I just don't understand why people are not okay with the uncertainty of how or why something worked, especially because it can cognitively pull you away from attempting to figure out what will work for that person in the moment. Part of the motivation for this is I stumbled across a social media post where it was talking about the inclusion or the shift to the hypothetico-deductive approach for RMTs specifically. The article that they were motivated by was about nociception. I believe it was about nociception. So talking very superficially about pain theory type stuff. So I would argue that hands-on practitioners do not target pain. It doesn't mean that they can't appropriately work through approaches that should help somebody feel different internally. It's just not a consistent, stable target that is observable to the practitioner. If it is not a consistent, stable target that is observable to the practitioner, then they are going to have to rely on the report of the individual they're working with. In most cases, these individuals will report what they're feeling in good faith because it benefits them. But you can't observe it. You can get as close as proxy. So somebody telling you something about something that's happening as opposed to you actually being able to observe it. Therefore, with respect to pain, you are always uncertain. It is not possible for you to be truly certain. Your certainty can go up quite high if you apply pressure to an area and the person moves rapidly in response to that pressure being applied in that particular area, and they make a noise and they say it hurts. Okay, well, your confidence is high. There's pain as a result of that interaction. It doesn't necessarily tell you why it's there. It doesn't tell you if it's going to stay there. It doesn't tell you how it's going to change. I'm confident that people who are deeply embedded in the concept of pain theory and approaches to pain diagnostics will have opinions about what I'm saying. And I grant that your opinions are valuable. I still would not consider pain as a useful target that is observable and consistent even within the same individual for clinical purposes. So that's the easiest one for me to point to as to not having strong concern as to the mechanism because I can't observe it in an appropriately direct manner. Things like why a patient active approach or a patient passive approach work. So you can break this out. Why does facilitated positional release work? Why does functional technique work? Why does strain counter strain work? Why does muscle energy work? Which form of muscle energy are you using? Are you using specifically PIR? Are you using RI? Are you using the oculocephalogyric reflex? Are you using respiratory assistance? Okay, like what are you doing? The why doesn't matter because it doesn't actually guide your decision making. So the reason that I was motivated by the term hypothetico-deductive approach is because when people talk about evidence-based medicine, they're saying that it is of high value to go out and read a bunch of papers and see what those papers say about the effectiveness. I don't like efficacy because efficacy is in lab setting. Effectiveness is, as far as I'm aware and how I'm using the terms, and if I'm screwing up, I'm sorry. But effectiveness is how something works out of lab setting, maybe more so in clinical setting, in applied clinical settings. So reading about the effectiveness of a particular approach, well, you're not that person, or you're not the people that were doing that approach. The patients that you're working with are not those people. The hypothetical-deductive approach is the scientific experimental approach. You have a finding, you have reason to believe that something will work with respect to that finding, you test it, and then you are able to detect whether or not it worked by how it responds after. If it didn't work, you now iteratively know that that method is out in that moment because you proved it. Then you go on to another methodological approach, okay? To rewind a little bit, EBM is suggesting what conscientious, judicious application of best available evidence. Screw that. Like, just stop reading what other people do. It doesn't mean stop reading scientific approaches and scientific papers. It means that they are unlikely to properly inform you how to solve the issue with the skills that you have, that the person who has presented themselves to use your skills as the end user needs. Just get over the term EBM and EBP. It's not going to guide you. It's going to pull you away from the situation that you are actually in. If you are a hands-on practitioner, you have a strong skill set that you can apply in response to the individual who's directly in front of you. If you are thinking about studies, you are unfortunately in a cognitively separate space from the one you're working in. You are not paying attention to that patient the way you could if you simply put your attention on them. You are in the moment together. You are trying to use your skills to help them solve the problem that they came for. Now, if they came for pain, you are probably going to net benefit them by finding what's not moving, working on it in a way that doesn't make them say ouch, proving that it's changed, and in all likelihood, if the mechanical reality of the restriction is why they were having altered sensation that was negative in its valence or its direction, then changing that will work. If it doesn't, the hypothetico-deductive method, the scientific experimental method, will tell you that your approach is not the appropriate one for that individual in that moment for that complaint. To iterate, or to sort of wind back a little bit to something I should have already said, pain is not a sign. It is a symptom. It is a highly varied symptom within the same person and between people. There are some stable enough category words that you'll probably have some good overlap, but even within that overlap, there is variance in those categories within the same person and between people. Knowing why something works doesn't help you solve the problem in the moment with the person who was presented to avail themselves of your technical skill. It doesn't matter why an indirect approach works. It doesn't matter why a direct approach works. It matters that when you try one and it doesn't work, you can try the other one. If you generate a pain response in a patient, say you go in the direction of restriction and you generate a pain response, the answer is, I am going indirect now. I'm going to make the soft tissue soft. Forget all of the verbiage that people talk about these different systems. It's window dressing. It's personal flair. It's not really how this stuff goes. If you are thinking about how strain counterstrain works, you are less likely cognitively to have available bandwidth to pay attention to how that person is responding to what you're doing. You're going to attempt to force the choice that you made on that person in that moment. That is not in line with the hypothetico-deductive approach. It is in line with evidence-based medicine, because if the person says certain words that line up with those words being the best candidate for strain counterstrain, you'll just do strain counterstrain, and you'll forget to pay proper attention to them. Okay? If you are using the hypothetico-deductive approach, which is what EBM should be based on, then you will figure it out with your patient or your client to the best of your ability in that moment. It is okay if you don't know why it works. It is not okay if you don't attempt to find what does work. You need a framework to choose between things, which is why I've chosen to use a heuristic-based framework, which are statements that allow you to choose. Is the patient active? Is the patient passive? How do you figure out which one to do? Well, try one first, and if it doesn't work, do the other one, right? It's a binary choice. You try one, and if it doesn't work, you don't do it. If you try passive and it's working and you want to see if active will further help, you add it on. This isn't a hard thing. If you try to add the active on and it doesn't connect the way you need it to, or it doesn't further the target goal that you have, you don't do it because you've tested hypothetico-deductively. You had the hypothesis that adding active would help. If it didn't help, you don't do it. It's really straightforward. If you've never heard this before, it may not feel straightforward. I may feel like I'm speaking a language that you don't understand. I get it. You don't need a lot of words to describe how to figure out what to do with the person in the moment. You do need experience and technical skill honed through decision making. You have a hypothesis, you believe the world will work a particular way, you test it in the way that you believe it will work, and if it does work, you can increase your confidence you were correct. If it does not work, you were wrong. I've seen a tendency for people to beat themselves up over trying to use a particular technical method and it not working, saying they're not skilled enough. It's actually more parsimonious, or it is a description that assumes less and explains more, that it was the wrong method for the person. Sure, you might not be technically skilled enough to apply that method properly. It's more likely that it was just the wrong method for the person in the moment. And then if you're not willing to think, if it didn't work, what can I try? Then you will run into similar roadblocks. There are definitely practitioners out there who use an exceptionally similar pattern of specific movements in an order on everybody. There is no adjusting for what they find. They would say that every movement is diagnostic and treatment, and it's only treatment if they find restriction. That's a fancy argument. It makes no sense, right? If you're not going to change your approach based on what you find, then what the hell are you looking for anything for? If you're going to do the same set of movements in the same order on absolutely everybody, you have no diagnostic approach. You have, at best, a ritual, right? Please be more cautious about this. I don't know why I feel like I'm speaking with more animation, but I am. So whatever, thanks. The uncertainty of the world, the uncertainty of clinical practice is normal. Stop throwing words at it to make you feel better or feel more accurate. If you talk about anatomy and you assume that you are accurate about the exact anatomy that you were palpating, I'm going to laugh in your face. You're probably close. But if you've ever looked at multiple anatomical resources, and this is just the books, the written information, they are not the damn same. If you can know, so you look back at some of the videos I've already done about motor nerve supply and arterial supply. I'm still working on attachment sites. So origin and insertion, if you don't like those terms because you're new and fancy, well, proximal and distal attachments. They're in the same areas, but the words they use are not the same. So if you have people learning from two different resources, you can't make a test for them because they're going to fight you on the details of the book they read. If you want to act as if you know anatomy, I'm sorry, you know a resource, you know a book. You don't necessarily know that this is variable and that how people are built is variable. Just because it says it in the book doesn't mean your patient matches that. In all likelihood, they're variable, at least in a small way, and sometimes in major ways. So using anatomical terms to define why you did what you did and why it worked, you are making assumptions. You could easily be right, but you could also easily be wrong. I understand that most people want to feel certain, to think it's okay to feel confident in what they do, but the uncertainty is the norm. You don't know how the person's going to respond to the move that you do until it happens. If you're unwilling to adjust and try something different, then you have a ritual, right? And your ritual failed you. You've got to be willing to pay attention to the person who's in front of you and test between methods to see what works best. If you say you're going to go patient active and you have a patient activate in a particular way first and it feels like it succeeded, maybe it did, but you have no idea if it was the best activation because you didn't try anything else. If you didn't try anything else, you know nothing. You just got lucky. Now, if you feel like you got lucky every time you've ever done a patient active method and where you have them contract works every time, I'm still going to call you lucky. The way that I'm going to do that is I'm going to ask you to activate that patient in a different way and see if it connects better. And sometimes it will and sometimes it won't. But if I can show you with consistency that sometimes the first thing you do is not the best thing, then I have shown you that you need to drop your confidence in, I just know what to contract because this is what the book told me about muscle energy. Well, maybe it's going to be too uncomfortable for the patient to contract. Maybe they're going to contract too hard. Maybe it's going to blow your shoulder out because you're fighting too many people in treatment. There's lots of considerations. But if you don't try anything else, you don't know anything else. Therefore, whatever you do is awesome and it works. Then you can come to the refrain that I have heard before. I've heard it in jest that the treatment was a success, but the patient was a failure. So I did the right thing, but the patient didn't take it well, right? That's also ridiculous. If you don't try different things just to see what will connect best, you don't know what connects best. You just know what you did. You don't know that what you did was the right thing. You just know what you did. You got whatever result you got, but you can't figure out how to get a better result in a situation that is more uncertain because you just do the same things in the same order for everybody. And then you come up with the fancy explanation that, well, every movement is diagnostic and therefore whatever I find in that movement is what I treat. But what if the solution for that particular individual does not lie in the movements that you do all the time? Then you're screwed. You're out of luck. You don't know what to do because you're using a rote memorization method. You are using things you think about prior to because of things you learned before, and you have no way to figure out whether it's the most appropriate thing. But what will do that is the hypothetical-deductive method. I believe I found this. I believe it should respond to this method. I will try this method. If this method works, I will know because it will improve the target movement. If it does not, I know I need to do something else. Therefore, you need a method to choose what the next thing should be. You need a method to choose what the first thing should be. Patient active versus patient passive. That's one. Direct or indirect. That's another one. All right, which tissue or tissues do I target? Well, the ones that don't move. That's always the answer. So hopefully the manner in which I am delivering this information has been useful in some way. I don't believe I usually communicate in this fashion, at least on camera. In person, probably, yeah. Maybe harsher. Who knows? Well, maybe I know. Whatever. But hopefully it's done something for an audience or for you as the audience that maybe the other ways I communicate has not done yet. The drive for certainty is going to kill your ability to pay attention to the person in the moment. You don't have to know what's going to work beforehand. You have to know how to figure out what's going to work now with the person who's in front of you. That is the hypothetico-deductive method. That is why, fundamentally, EBM has shortcomings. EBP has shortcomings because it's relying on the questions that other people have already asked. And also, you have to assume that what you have read and how you've interpreted it is germane or appropriate to the situation at hand and going to work. And if it's not, and you don't have the hypothetico-deductive method, you won't damn well figure it out. So have a good assessment, find what's not moving, work on it in a way that you believe it will improve, and if it doesn't, have a series of choices you can make subsequent to your first choice that would allow you to find what will work best for that person in that moment. And don't hang yourself and your confidence on knowing exactly why something worked. It is outside of your realm of observation. You're probably not going to know. But if you have a choice framework for how to figure out what the person's going to respond well to and what those good responses look like, then you will be able to solve with that person in that moment what is going to work best for them with your skill set. If it is a target you can't observe, you can't aim at it. If you think you're going to change something physiologically, you're nuts. At least if you think you're going to do it on purpose. If it happens because it was properly related to the mechanical restriction you found, that is normal. If it does not change based on the mechanical restriction you found, then it is not appropriately related. Therefore, you have learned that your approach with hands-on manual therapeutics is not going to work the way that the person needs it to work or wants it to work. And that's fine. But the hypothetical deductive approach will allow you to figure this out. So a lot of what I'm saying is just in support of the hypothetical deductive approach. So for the individual who had posted something arguing for that, I think that's on the right track. Maybe some of the details I don't agree with as much. Totally fine. But at least if you have a way to develop a hypothesis, aka a prediction as to how things work, and then test it in a way that if it does work, you see it, and if it doesn't work, you also see it, well then you're on the right track. So thank you for listening this far. Hopefully you've learned something, and we will talk again soon.